In this session, we're going to discuss management of difficult stomas. Now, I want to explain that I'm going to go over some general concepts, things to think about, issues and factors that lead to difficult stomas, and a pathway for management. But you are also going to have a session on management of difficult stomas when you come on site that will give you the opportunity to look at specific products in more detail and to actually do some hands-on. So let's talk about why we have so many patients with difficult stomas in 2014, and probably more to come in 2015, etc. Obviously, what we would like is what you see on top. We would like to see a protruding stoma on a flat surface for all of our patients because we know that that makes management so much easier. We can use almost any pouching system and it will be successful. It's relatively easy for those patients to establish a secure pouching system so that they can move ahead with their lives. But in reality, we're having an increasing number of patients who have stomas that are skin level or retracted. We're having more and more patients who have stomas located in deep creases or in very irregular abdominal contours. And for those patients, it's much more difficult to achieve a secure pouching system and to enable them to move ahead with adaptation. One factor that's leading to a lot of difficult stomas is the increase in abdominal obesity. Now, you probably remember from the discussion on stoma site construction, stoma site marking, stoma site construction, that obesity negatively impacts the stoma site in two ways. First of all, as you know, the bowel is attached to the mesentery, and the mesentery in turn is attached to the posterior abdominal wall. So in creating the stoma, we have to mobilize the bowel and mobilize the mesentery. We can't take the bowel anywhere the mesentery doesn't want to go. Unfortunately, with abdominal obesity, the mesentery becomes very short and thick and immobile. So it limits the surgeon's ability to mobilize that segment of bowel and to take it to the place where we would like for that stoma to be located. The second thing is that thickness of the abdominal wall itself impacts on whether or not the stoma protrudes, is skin level, or is retracted. And I'm going to try to show you this on the board. I don't know how well you'll be able to see it, and if you can't see it well, that's okay. You can ask about this when you come on site. But here's the thing. When the surgeon constructs the stoma, he or she does not bring the mesentery through the abdominal wall because the mesentery is a bunch of blood vessels suspended in a membrane. And if we pulled the mesentery through the abdominal wall, we would create vessel compression, clot formation, etc. So instead, what they do is they trim away the mesentery on the section of bowel that is going to be used to construct the stoma. Now, there's a limit to how much mesentery can be trimmed away from the bowel without causing necrosis of the stoma itself. And the limit seems to be somewhere around 7 centimeters, right at 3 inches. So I want to show you the impact of abdominal wall thickness on stomal height. I want you to assume that this section right here represents the section of bowel that will be used to create the stoma that we will feed through the abdominal wall. This line that I've drawn represents the fascia muscle layer and the entry into the abdominal cavity. Now let's start with a patient who has normal thickness abdominal wall. So this is their abdominal wall. And when the surgeon brings the bowel through, you can see that there's a significant length of bowel protruding past the abdominal wall, so the surgeon can easily turn the stoma back on itself, suture it to the dermis, and you would end up with a nice protruding stoma. Scenario number 2. The patient's abdominal wall is right at 3 inches thick. So you can see that what's going to happen here is that the stoma just reaches the abdominal surface, and the patient's going to come back with a skin level stoma. Scenario number 3. The patient has abdominal obesity and a much thicker abdominal wall. Let's say the abdominal wall is 4 inches thick. So here's where the abdominal wall ends. And here is where the bowel ends. So you can see that you have a major problem. What is the surgeon going to do? He or she could trim more mesentery and pull the bowel out, but then the stoma is going to necrose, so you haven't gained anything. So the bowel is not mobile in this situation, but the skin is, so they end up pushing the skin down to create the stoma, and the patient comes back from surgery with a retracted stoma. That's no one's fault. I used to think, before I knew very much about stomal construction, when patients came back with these retracted stomas, I thought, what were they thinking? Now I realize they weren't thinking anything different than me. They just had limitations on what they could do. So I want you to be aware of that, the impact of obesity. I also want to go over with you your 3 major strategies for establishing an effective pouching seal and pouching system in a patient with a difficult stoma. First of all, you've got to look at stomal height and peristomal contours, and you have to do the best job possible in matching the pouching system to the abdomen, to the stoma and the abdomen. We're going to talk about this in more detail. Secondly, if I have irregularities in the abdominal surface and the peristomal surface, I want to use filler products to create the flattest surface possible, because I want the pouch to adhere securely to the abdominal wall. And if I have a lot of defects in the abdominal wall, I'm not going to get a secure seal. So first of all, I look at the stoma, look at the abdominal wall, look at what I have available in terms of pouching systems, and make the best match possible. Secondly, I look at the abdominal surface itself, and I use my filler products to create the flattest surface I can. And then I look at accessory products that could improve my seal. And they tend to fall into 2 categories. First of all, we have belts and binders that we can use to provide mechanical support and mechanical retention. And secondly, we have adhesive products that we can use to improve the actual stick between the pouching system and the pouching surface. So go back to square one. What have we been talking about in terms of rehabilitative care? You've heard over and over again that a secure pouching system is absolutely critical to the ostomy patient's quality of life. It is their key to continence. We've talked about the fact that you can't expect patients to move back into their usual activities until you establish a secure pouching system. And yet, we're talking about the fact that for many of our patients, that's much more difficult than it has been in the past. So again, we would like to see a stoma like you see on the bottom right, but we frequently see stomas like you see everywhere else. Top left, top right, mid, and bottom left. So we're going to talk about those. They tend to fall into 3 major categories. Either you have a stoma that is in a crease or right next to a crease. Some of those creases are very deep, as you can see here. So here you can't even see the stoma is in such a deep crease. If the stoma is in a crease or immediately adjacent to a crease, that crease is going to dictate the type of pouching system. Many times we have retracted stomas. So a stoma may be retracted to skin level so that there's no protrusion, but you have a flat stoma and hopefully a flat pouching surface. Or sometimes you see this, where the stoma is retracted below skin level and it's sitting in kind of a valley, a defect. And then we have to fill that defect. We have to select a pouching system that matches the defect contours to the abdominal contours. And then finally, we have a lot of patients who have a combination of a stoma and a wound. Maybe they have mucocutaneous separation. Maybe they have pyoderma around the wound. So we have to be prepared to manage those patients as well. We've talked about those briefly in the past. We'll talk about them briefly today. Now, on your handout, if you're looking at your hard copy module or your online materials, when we start walking through the different types of problems, we started with retracted stomas and talked about convexity. I'm actually going to switch the order a little bit, and I'm going to start by talking about stomas that are located in or adjacent to a crease. The reason I'm going to switch the order a little bit is because the presence of a crease, either immediately adjacent to the stoma, like the stoma is sitting in a crease, or the stoma is just above or just below a crease, is the determining factor for what type of pouching system you're going to use. So we're actually going to start by talking about stomas in a crease. Then we're going to move to talking about stomas that are retracted. Now, before we start talking about specific solutions to specific problems, I want to go back and review a concept that we've discussed previously, and that is our three options when it comes to pouching systems and the way in which they interface with the abdominal surface. Some pouches are all flexible. That means that I can literally bend this pouch in two and it will stay there. So when I have a patient with a very deep crease, I'm going to need a pouch that will follow those contours. I'm going to need an all-flexible pouch. Most of your all-flexible pouches are one-piece pouches. So when you look at the products that you have in stock, look carefully at your one-piece pouches. You probably have one-piece pouches that are totally flexible. Most of Convatec's, most of Hollister's, most of Coloplast's one-piece pouches provide total flexibility. So you definitely want to make sure that you have a totally flexible pouch in your inventory. And we're going to talk about when that flexibility is essential. Your two-piece pouches, most of your two-piece pouches have rigid components because they have the flange that allows attachment of the pouch. Now, when you come on site, we'll talk more about the fact that there are emerging systems that rely on adhesive coupling that provide partial flexibility. They don't provide the same level of flexibility as your one-piece systems. Two-piece systems also come with convexity. And of course, convexity is an outward curve of the barrier plate. And it's designed to match an inward curve of the abdomen. So if your stoma is sitting in a defect, sitting in a valley, and the abdominal surface curves in, you need a pouching surface that curves outward so you get a match. So basically, when we look at pouching systems, we look at all flexible, which is frequently helpful for deep creases. Also can be helpful when you have a very rigid abdomen because it's just going to follow the contours of the abdomen. You have your pouches that are flat with rigid components. These pouches are primarily effective for normal protruding stomas. Most of the time you will not use flat pouches with rigid components for problem stomas. Most of your problem stomas will either require flexibility or convexity. So for creases or very rigid abdomens, you think about flexibility. For skin level stomas and retracted stomas, you think about convexity. Most of the time, use of your standard flat pouches with rigid components like your two-piece systems, most of the time those systems are limited to use in patients who have relatively normal stomas, relatively normal abdominal contours. So I just wanted to review what we mean when we say flexible and convex and rigid before we move ahead with specific issues and specific solutions. So let's talk about stomas in a deep crease. You can see here, both of these patients have a stoma in a deep crease. You literally cannot see the stoma. The patient on top was my patient, and I can tell you that the distance from the abdominal wall to the stoma itself was 3 inches. A very, very deep crease. The patient on bottom was not my patient, but I can see that there's a deep crease, and I can see that the stoma is not visible. Excuse me, I forgot to enlarge this so that you can see it better, and I apologize. I'm going to do that right now. Okay, so hopefully you can see those creases a little bit better. If you have a stoma in a deep crease, you are going to need an all-flexible system because it requires flexibility to contour to those creases. You cannot fill those creases effectively and use a flat pouch. It doesn't work. If you do fill those creases so that you can use a flat pouch, almost always the stool or urine will run under your filler product. You can try it, but I'm just telling you, most of the time, that's not effective. So usually what's effective is to select a pouch that actually contours and fits in around the stoma. Now, there's a little bit of difference in how you size the opening in the pouch depending on whether the stoma protrudes or is flat. If the stoma protrudes, so there's a deep crease above, below, or immediately adjacent to the stoma, but the stoma itself actually protrudes, then you would size the opening in the pouch to fit closely around the stoma. So if it's a 1.5 inch stoma in a deep crease or just above a deep crease, you're going to size the opening in the pouch right at 1.5 inches, maybe a tiny bit larger, so that it gives very good skin protection. But notice that if the stoma is flat at skin level or it's retracted to below skin level, you want to give a little bit of clearance around that stoma, and this is why. As you have observed, if you've done stoma care, the stoma changes. It changes size and shape with peristaltic activity. Now, if my stoma protrudes and I have a soft barrier around that protruding stoma, there's no problem because even if the stoma expands a little bit, the barrier expands a little bit. The stoma comes in, the barrier comes in. So with a protruding stoma, very appropriate to size the opening in the pouch or barrier to fit around the stoma. But if I have a skin level stoma, the issue is that with peristalsis, the stoma can expand. So it can go from this to this, this to this, this to this. And if I have sized the opening in my pouch to fit right around the stoma, and it's an all-flexible system with no support for the peristomal skin, then what can happen is that as the stoma enlarges, it stretches out underneath the barrier, wets the barrier, and creates a pathway for undermining. So most of the time, if you're using an all-flexible system in a deep crease, and your stoma is skin level or retracted, you want to size the opening in the barrier wafer 1/8 to 1/4 inch larger than the stoma to give a little bit of clearance. You will, of course, protect the exposed skin. If it's a fecal stoma, you're going to use flat paste. We'll come back to that concept. And if it's a urinary stoma, you'll use a skin sealer. But just think about the difference in sizing. You're using an all-flexible pouch anytime you have a deep crease. If the stoma protrudes, the pouch can fit snugly. If the stoma is flat, you need to provide some clearance. Now, what about a belt? What about a binder? That's something that people think about a lot when they start managing difficult stomas. I need to attach a belt to hold it in place. But here's the problem. Your all flexible pouches do not have belt tabs, because that belt ring and the belt tabs themselves create rigid components in the pouching system. And what have we just said? In this situation, we need all flexible. So a belt is not an option when you're using an all flexible pouch. There are no belt tabs in totally flexible pouches. Well, what about a binder? Look again at the contours here. If you look at the patient on top, adding a binder is not going to help, because the binder is designed to fit around the pouch and provide support. And the pouch is going to be in a deep crease. This is not going to fit into that deep crease. So belts and binders in general are not an option when you're dealing with stomas in creases or immediately adjacent to creases. So that's why we go back to premise number one. If you're dealing with a stoma in a crease or immediately adjacent to a deep crease, that dictates your pouching system. It has to be flexible to contour to that crease. Beyond that, you have to look at stomal height. Protruding stoma, size snugly. Flat or retracted stoma, provide some clearance and then protect the exposed skin. There are different rules when you're managing a stoma in a shallow crease. And I want to show this patient to you and help you understand the difference in a shallow crease and a deep crease. This patient was also my patient. And I don't know if you can tell, but this is actually the stoma right here. You can actually see the stoma just looking at the patient in a sitting position. The depth of the crease was 1/4 inch from skin surface to the base of the crease. You can see it's very shallow crease. And the patient on top also had a very soft abdomen, meaning that when I palpated the abdomen, there was a lot of pliability, what we used to call jelly bellies, a lot of give. That means that when you're managing stoma in a shallow crease, you have the option in some cases to use convexity. Other cases will still require flexibility. So when is convexity a good choice? Well, I've outlined it here on your slide. An oval convex pouch or a round convex pouch. Many times these stomas are oval when they're in creases, so that's why I said oval is usually best. But if your stoma happens to be round, you would use a standard round pouch with convexity. If your abdomen is soft, convexity usually works best, and this is why. I place the patient supine, or the patient stands to apply the pouch. When the patient's lying or standing, what happens? That crease stretches out and they're putting the pouch onto a relatively flat surface. So they apply the pouch with convexity, and then when they sit up, if the abdomen is soft, the abdomen will just contour around the stoma, not around the stoma, around the pouch. Basically, the abdomen will follow the contours of the pouch. So when you have a soft abdomen and a shallow crease, you can frequently use a convex system. That is true whether the stoma protrudes, the stoma is skin level, or the stoma retracts. The determining factor is how soft is the abdomen. A soft abdomen, convexity will provide the support needed. You're going to put the pouch on and you're going to basically support the peristomal skin and soft tissue in that retracted position provided by convexity. In contrast, if I have a patient with a very firm abdomen, a six-pack type of abdomen, I palpate, there's very little give, then that abdomen would not conform to a convex system, and I would need to use an all flexible. So deep creases, you always have to use all flexible. Shallow creases, you have to look at the abdomen. If it's soft, you can do a trial of convexity. If it's firm, you're probably going to need to go all flexible. Now, one of the advantages, if you're able to use convexity, is then you can usually add a belt or a binder, because most of your convex systems do have belt tabs. So that allows you to add a belt or to add a binder. Now, let me just mention the difference between a belt and a binder and when one would be better and when the other would be better. If you look here, you see that this patient's wearing a belt. Belts work well if the stoma is located very close to the belt plane. So let me just move over so you can see what I'm talking about here. So if my stoma is located very close to my belt plane, then I can add a belt and it will provide wonderful mechanical support. It will hold the pouch in place. And of course it provides support primarily at 9 o'clock and 3 o'clock, but bottom line, it cinches the pouch against my abdomen. But what if the pouch is not located anywhere close to my belt line? What if the stoma and the pouch is located in the right lower quadrant or the left lower quadrant? Then if you attach a belt, it's just going to ride up. That would not be effective. When your stoma is not located close to the belt plane, that's when you would think about a binder instead. This is a specialized binder that I'll explain in a minute, but I'm going to start out by explaining the basics. So with a binder, you can get them in different widths. So you can get 4-inch, 5-inch, 6-inch, 8-inch. And that just depends on the area of the abdomen, how much of the abdominal wall needs support. The opening and the binder will be customized based on the pouching system that the patient wears. You'll have this ring, and the pouching system will fit through the ring. So this probably isn't going to fit exactly right, but I'm just going to show you kind of how it would work. I might have to use my 2-piece system instead, since I didn't get a 1-piece that fits. So I hope you can see that my 2-piece system, I'm fitting the binder around the flange of my 2-piece system. That locks the binder into place. The advantage of a binder is that you can get it in multiple widths. You can get it sized so that it works for any pouching system, and it will work for stomas that are not in a belt plane. So if you're thinking you need mechanical support, you look carefully at the stoma. The problem is it's not located in the belt plane or anywhere close to the belt plane. Then think about a binder. That's an alternative approach to mechanical support. You should also be aware that patients can take undergarments, support undergarments, and they can use a plastic ring and customize support for their pouch, their stoma, or they can send an unworn undergarment appropriately marked to New Hope, and they will customize an undergarment for $20. So lots of options for support. Anytime you're putting a patient in a system with convexity, you think about, would it help to add a belt? Would it help to add a binder? And then your decision making is, where is the stoma? Close to the belt plane? Go the easy, inexpensive route, add a belt. Away from the belt plane, you're going to be forced to look at a binder or a support undergarment that can be modified to allow you to pull the pouch through. So here you see a binder. Here you see a patient wearing a belt. Here you see multiple pouches with convexity. That would be one option. This patient had a very soft abdomen. But if she failed the trial with convexity, I would revert and I would trial all flexible. Many times when I have patients with stomas in shallow creases, I will try both I'll try both convexity and flexibility, and I'll see which one works better for that patient. Whichever works best for that patient, that's what we're going to use. So to summarize, management of stomas in or adjacent to creases. Deep creases, you have to use an all-flexible system. The only thing you have to decide is, should I size it to fit closely? And you should if the stoma protrudes, or should I give some clearance, which is what you should do if the stoma is skin level or retracted. If you have a patient with a shallow crease, you have two options. If the belly is soft, you can try convexity to lock the tissue into place and provide support around the stoma, and you can add a belt or a binder. If the abdomen is firm, you will typically need to use an all-flexible pouch, and then of course you would not be using a belt or a binder. So I've talked about stomas in or adjacent to creases. That's where I would recommend you start your decision-making process. Now let's talk about stomas that are retracted. That's another very common problem, is stomal retraction. We've already talked about why that is. And again, you're going to come back to, is there peristomal creasing? So if the stoma is on a relatively flat surface, you're going to use convexity. And I want you to look at the two slides on the top. So the slide on the top, you have a stoma that's right at skin level, and the surrounding abdominal contours are pretty flat. There's very minor creasing, but those creases will be managed effectively with convexity. The slide here shows a stoma that is retracted, is below skin level. So the stoma itself is located in a concave valley, but beyond that point, the abdominal contours are flat. So here we would be looking for convexity to fill that defect. We would want a pouching system that gave us the best match possible to that concave defect. And I'm going to show you a pouch, if I can pick it back up or find it. Where did I put it? Sorry. So I hope you can appreciate the bowl-shaped convexity of this pouching system. That's what I would be looking for, because I need a pouching system that contours to the concavity of the peristomal surface. But then, look at the two slides on bottom. This one you've already seen. This patient has a retracted stoma located in a deep crease. This patient has a skin level stoma with a deep crease adjacent on the lateral side. So when you have a stoma that is adjacent to or in a deep crease, you usually need to use an all-flexible system. That's why we started our discussion by looking at creases. Creases matter. So you start by looking at creases, and then you factor in stomal height. Retracted stoma, flat surface. Retracted stoma in a valley surrounded by a flat surface. You're going to use convexity. And you're going to add a belt or a binder most of the time. Belt for stomas in the belt plane, binders for stomas away from the belt plane. In contrast, retracted stomas in or adjacent to creases, you're going to need that all-flexible system. You're going to need a little bit of clearance to minimize undermining, and then you're going to need to protect the exposed skin, either with paste for fecal diversions, paste or paste strips, or with a skin sealant for urinary stomas. Now let's talk a little bit about convexity and the options you have with convexity before we move on and talk about stomas and wounds and some other issues. Convexity is a major tool that you have in solving pouching problems. And convexity, as is covered in your online and hard copy materials, You can see the advantages that convexity provides. It supports the peristomal skin and tissue, so it helps the drainage project into the pouch. Sometimes it actually increases protrusion of the stoma slightly. Most importantly, it contours to concave defects in the peristomal skin so that you get a good match between the pouch and the skin and you prevent undermining. So by matching the peristomal contours, by providing support directly around the stoma, you minimize the risk for undermining and you tremendously increase the potential for the stool to go or the stool or urine to go directly into the pouch. You significantly improve your chances of establishing a secure pouch and seal for patients with skin level or retracted stomas as long as the surrounding abdominal wall is relatively flat. But there are many convex products on the market and they're not all the same. So I wanted to go over the difference in convex products. Probably the most important difference from our way of thinking is the level of convexity. So you can get pouching systems that have low level convexity. So there's a very slight convexity, and this is going to be effective for patients with skin level stomas or with very minimal concave defects. You can also get pouches with deep convexity. Deep convexity is primarily available from Marlin and New Hope. That information is on your handout, and you'll discuss that on site. When you look at the contours of a pouch with deep convexity, it's almost like a bowl-shaped contour, and it's going to fit into a significant concave recession in the skin. So, shallow convexity for skin level stomas, deep convexity for deeply retracted stomas like you see on the bottom. So the first thing you think about is, do I need standard shallow convexity? Do I need deep convexity? Secondly, you can get convex pouches that are relatively soft, and you can get convex pouches that have a lot of firmness and a lot of support. Most of Marlin's convex pouches are relatively flexible. So even though they have a lot of convexity and fit into deep concave areas, they're pretty flexible. So they're very comfortable for the patient. Even if the patient has a relatively firm abdomen, they tend to just fit and accommodate. Let me get this other pouch. This is a 2-piece system with convexity. This one happens to be from Hollister. It's low-level convexity. But there's practically no flexibility. This is a very firm faceplate or barrier plate. So this would be a great choice for a patient with a skin-level stoma and a soft abdomen because you would get the support you need right around the stoma. So sometimes all you need is a convex contour that fits into the defect, and then you want the pouch to be relatively flexible for comfort for the patient. That's particularly true when the patient has a firm abdomen. At other times, you're going to want a convex system that provides both convexity and support, and that would be appropriate when the patient had a very soft abdomen. Okay, so you pick and choose. They're available round, like you see here, and oval. And of course, whether you select round or oval will depend on the shape of the stoma. And then finally, they're available pre-cut and cut to fit. And whenever possible, you want a pre-cut convex system. And this is why. If I have a pre-cut convex system, the support will be right at the level of the stoma. I'm going to get firm support right around the stoma itself. It's going to push in around the stoma, minimize the risk of undermining. If I have a cut to fit, see if I can find where I hid my cut to fit. If I have a cut to fit, the problem is that the ring that makes this pouch convex is way out here. And all the intervening material is just barrier and it's very soft. So the advantage is this is a great inventory item. I can keep it in stock and I can individualize the opening for individual patients, but I will not get the level of support that I frequently need. So just know that pre-cut is going to give you a lot more support. Cut to fit is going to give you variability, the ability to individualize it for individual patients, but it's not going to give you the level of support. What about patients who have multiple skin wrinkles? So you're going to have some patients that when they're sitting up, the entire peristomal surface just folds into wrinkles. When they lie down or they stand up, stretch out, the wrinkles go away. You're going to look at the softness of the abdomen in deciding how to deal with multiple wrinkles. Some patients have that very firm abdomen, no give, more like a six-pack. And other patients have very soft abdomens. The patient on top had a very soft abdomen, and I hope you can appreciate multiple skin wrinkles. When you have a very soft abdomen, you usually want a firm pouching surface because the soft abdominal wall will contour to the pouching system. Your pouch will give that soft abdomen needed support. So in that case, I would palpate the abdomen. If it's soft, I'm looking for a firm pouch. How am I going to size the opening in the pouch? If the stoma protrudes, I will size to fit right around the stoma. And I'll do that whether I'm using a flat firm pouch or a convex firm pouch. It's going to be sized to fit right around the stoma. If I have a skin level stoma, then I really do need a convex pouch. So let's back up and go over that again. Soft abdomen, I want a firm pouch. I already know that. I've got all these wrinkles. I want to provide support to the peristomal surface. So wrinkles, soft abdomen. I know I need a firm pouch. Then I just have to decide, can I use a flat, rigid pouch that provides support, or do I need a convex, rigid pouch with support? And that is determined by stomal height. If my stoma protrudes, I'm going to use a flat, rigid pouching system, not rigid, but for example, a two-piece system that will provide a lot of support, readily available, will provide a lot of support. I'm going to size it to fit closely around the stoma, put it down. It's going to support the peristomal contour, smooth out the wrinkles because I'm going to put the pouch on when the patient's lying or standing. If the stoma is skin level or retracted, then I'm going to use a convex system. So I can use either flat rigid or convex rigid. Flat rigid for protruding stoma, convex rigid for skin level or retracted stoma. Okay? If my belly is firm, this patient had a very firm abdomen. If I have a firm abdomen, then a firm pouching system usually doesn't work because I have board-like, nothing's going to contour. So when I have a board-like abdomen, a very firm abdomen, I want a pouch that will contour to that surface. So now I'm looking for flexibility. And if it is a protruding stoma, usually a very flexible pouch gives you the best option. There's actually pouches on the market that have a transparent adhesive dressing surface. You can't get more flexible than a transparent adhesive dressing. So let's say I have a patient, firm abdomen, so I'm looking more the flexibility, multiple wrinkles, protruding stoma. If I can get a very soft, very flexible pouch, that will be perfect for that patient. Size it to fit closely around the stoma, put it on when the wrinkles are all stretched out, and then when the patient sits, that very flexible pouch is going to contour to the wrinkles. Okay, firm abdomen. The pouch has to be conformable. What if I have a skin level stoma? Firm abdomen, lots of wrinkles, skin level stoma. Remember that you can get convex pouches that have some degree of flexibility. For example, the Marlin convex pouches have flexibility. So here I have two challenges. I have my skin level stoma, and then I have wrinkles, but the rest of the surface is relatively flat. So I have to think, okay, now what's my usual solution for a skin level or retracted stoma? Convexity. Well, what's my usual solution for a wrinkly abdomen? Flexibility. So I'm going to select a convex system that has as much flexibility as I can get. And I'm going to select the depth of convexity based on the contours. If the stoma is deeply retracted, then I want deep convexity with some flexibility. If I have a stoma that's skin level, like you see here, with all of the wrinkles around it, then what I'm going to do, there's two things I'm going to do in this case. I'm going to use a filler product to fill in between the wrinkles so that I have a relatively flat surface. I'm going to get a pouching system that provides low-level convexity, because this stoma is essentially skin level, and flexibility. So I'll use filler products so that I create a flat surface. I'll use convexity so that I provide support right around the stoma to help the drainage project into the pouch, and I'll use flexibility because the patient has a firm abdomen. So you see that many times there's mixed problems. I have skin level stoma. Okay, that usually requires convexity. Will convexity work? Yes, in this situation. What particular form of convexity should I use? Convexity with flexibility, low level convexity because the stoma is retracted only to skin level. Do I need to take any action to improve the abdominal surface? Yes, I need filler products to improve the abdominal surface. So many times you're having to pull from this, this, and this. And what I want you to start thinking, what we want you to start thinking is decreases, you've got to go all flexible, you've got to think about sizing, you can think about adding adhesive products for additional support. But with deep creases, your options are limited. With shallow creases, you have increased options. So with shallow creases, you can think about convexity if you have a soft abdomen. You can think about all flexible if you have a firm abdomen. And if you have minor defects in addition to the significant crease, you can fill that minor defect. If you have a patient with a retracted stoma, you think, okay, ideally I want to use convexity, but I have to again factor in, are there creases and how soft is the abdomen? That allows me to determine whether I can use convexity, what type of convexity I should use. If I have significant wrinkles, then I can think about using filler products to create a slightly flatter surface, stretching everything out for pouch application. And again, I go back to, is the abdominal surface soft? Then I can use convexity, or flat rigid. Is the abdominal surface firm? Then I need to use a flexible pouch. Gullies and defects, the simplest problem to solve, fill it. And we have a lot of filler products. Our filler products fall into three categories: paste and paste strips. I'm going to kind of talk about them together. And then your barrier rings that can be shaped to fill defects of different sizes, okay? Now, I have to look at the depth of the defect. Is it a very minor defect? Then I'm probably just going to use a little bit of paste. But if it's a major defect, I'm going to use my paste strips or my barrier rings. I'm going to roll them into a shape that contours to that defect. So in looking at these two situations, if I was going to do a filler product here to create a slightly flatter surface before I added my convexity, or to create a flatter surface for my all-flexible system, then I could take either paste or a barrier ring. I would want to make sure that I flattened it out where it comes right next to the stoma, because the stoma empties its skin level. So when you look at the stoma on top, you've got a pretty deep crease. Your first thought would be, I'm going to use an all-flexible system. If you had trouble maintaining a seal, you could go back and add a little bit of a filler product to see if that gave you a better seal, if that improved your pouching outcomes. If you look at this patient has a very minor defect here that I could fill just with paste. This is the groin crease. This is a very deep crease. I'm going to need to fill that defect here to give me a flatter surface, a better chance of success. Paste is not going to give me enough support. That's where I would want to use one of my barrier rings rolled into a kind of little cigar and packed into that defect. Okay, just a few more challenges to go over, and then we're going to look at some case studies. So here you have a stoma in a wound. We've talked about this before. You always start with the wound, and you're going to select an appropriate dressing for the wound. When you look at this, you think, well, I might use an alginate, I might use a hydrofiber. I'm going to tuck that in around the stoma. That's going to absorb exudate, maintain a moist wound surface. If you felt like an antimicrobial was needed, you would use a silver alginate or a silver hydrofiber. Then you're going to put something on top of the dressing to create a pouching surface. It could be a thin hydrocolloid, it could be a thin foam dressing, it could be tape strips. Then you're going to select the pouch itself based on the stomal height and peristomal contours. And so you're looking at this and you're like, wow, the stoma really dips down into a valley. But that abdomen's pretty firm, so I would probably be looking at convexity, but I would want a convex system that provided flexibility. I don't want to add a lot of pressure to that firm abdominal surface. And then you would think, should I do anything else? Well, look at where the patient's umbilicus is. The stoma is well below belt level. So I can't add a belt, it won't help, it will ride up. I might think about adding a binder or a support undergarment. It would depend on the patient's activity level, what else going on. So let's try to put all of this together and see if I can help you make some choices. The patient comes in, I can't keep a pouch on. This thing's driving me crazy. I had to change my pouch this many times yesterday. I can't live like this. You've got to help me come up with something. That's usually how they present, very, very frustrated. And you can understand. And as an ostomy nurse, you're going to be in that very same position sometimes when you're just as frustrated or almost as frustrated as they are. But here's what you tell that patient. We are going to work together to get you to a better place. So let's start by looking very carefully at what's going on. I want you to tell me how long you've been having problems. Have you used more than one pouching system? If so, which one has worked the best? Have you tried changing the size of the opening? Has that made a difference? What kind of accessory products are you using? You want to get a pretty complete history as to how they're managing. Then you do this assessment yourself. You take off the pouch. You evaluate the patient both in the sitting and the supine position. Also, when you take off the pouch, you look at the back of the pouch, and you look at areas of the pouching surface that are wearing away. That tells you where leakage is occurring. Okay, so I've looked at the patient sitting and lying. I've assessed stomal height. I've watched to see what happens to stomal height with peristalsis, because sometimes with peristalsis the stoma retracts and the patient gets undermined. So if I have a skin level stoma, a retracted stoma, if I have a stoma that retracts with peristalsis, I'm thinking, can I use convexity? Is that an option for this patient? But I've also got to look at the peristomal contours. What if that stoma is in a deep crease? I have to go all flexible. What if it's in a shallow crease? Okay, I can try convexity and I can try all flexible. So in selecting a pouch that provides the best match to that patient's contours, I have to think about two things. The peristomal contours themselves, the abdominal surface, and stomal height. So both of those things matter. Okay, so I've picked my pouching system. Now I'm going to use filler products to fill any defects and to give me the flattest surface possible. And on the slide you see I have made a note, ramp versus retaining wall. So I'm going to try to make this clear to you. If it's not clear, that's okay, because you are coming on site and we can make it clear to you then. So I'm going to try to hold this up. Here I have a stoma that protrudes. So when the stoma protrudes, I don't have to be particularly careful with my paste application. Come on, paste, work for me. I can just put a big ring of paste all the way around. And it can be a thick ring. It can look like a retaining wall. My paste does not want to work. I don't have to worry about flattening my paste out. If you can see this, you can see the stoma protrudes and I have a thick ring of paste all the way around. Not a problem, because my stoma empties at a point higher than the highest level of my protective products. The rule of thumb is any product that you use for peristomal skin protection has to match or has to be flatter than the stoma itself. So if I have skin level stoma, I have to have flat paste. If I have a protruding stoma, I can have a ring of paste. So if my stoma protrudes, it's fine to have a retaining wall. But if my stoma is skin level, if I have a flat stoma, then I have to apply my paste in a very flat manner. Because if I do a thick ring, what I do is create a barrier to drainage of the stool or urine into the pouch. So I'm going to do as flat a layer of paste as possible. And I'm going to wet my glove finger and I'm going to smooth the paste out. And you'll do this on site. You will practice flat paste versus ring paste. But I want you to be very aware of that rule of thumb. This is a problem many times in clinical practice, because clinicians and patients, and I can understand this because I thought the same thing. They think if I have a problem, I need to add more paste. I need to add more protection. And they caulk it up good. But if your paste is this high and your stoma is this high, what's going to happen? The drainage is going to go under. So when you have a flat stoma, your paste should act like a ramp. It should be totally flat next to the stoma. It's okay if it's a little thicker out here, It's got to be flat next to the stoma so that the drainage runs up and over. So protruding stoma, ring of paste, flat stoma, flat paste. Then gramp versus retaining wall. Okay, think about mechanical support devices. Can I use a belt? When can I use a belt? First of all, I have to have a stoma that's in the belt plane, and secondly, I have to be using a pouch with belt tabs, which means a pouch with some rigid components. If I want mechanical support, but the patient's not a candidate for a belt because the stoma is nowhere close to the belt plane, I can think about a binder. Should I think about additional adhesive? We haven't really talked about this, but there's an adhesive product available. This is Hollister Medical Adhesive Spray. It's a silicone adhesive. There are very, very few patients who have allergic reactions. I've never had a patient with an allergic reaction. It can be used with anyone's product. So if I was going to use this, after I size the pouch to fit around the stoma, I would simply spray it with the Hollister adhesive spray, and then I would sit it to the side for about 1 to 2 minutes so that it can dry before I put it on. It just tremendously increases the stick between the pouch and the abdominal surface. So that's always worth thinking about as well. So your basic pathway, thorough assessment. Pick the pouch that's the best match for that patient, considering peristomal contours and stomal height. Contours are most critical. So if you're dealing with deep crease, all flexible. Shallow crease, think 2 ways. Think I could try convexity, especially if the abdomen's soft. I could try all flexible, especially if the abdomen's firm. Use filler products to create the flattest surface possible. Add mechanical support if that's feasible, if you have belt tabs, if the patient's a candidate for a binder. Add an adhesive, we almost always do that because it might help. And then tweak. So you tell the patient, okay, here's what we're going to do today. I cannot guarantee that this is going to be the final solution, but it's step 1. And I need you to tell me exactly what happens. If this pouch leaks, I need to know when it leaks. I need to know where it leaked. And then we're going to go from there. Now, what if you've done all of these things and you haven't come up with an effective solution for this patient, and you and the patient are both frustrated to the max? You're to the point where it's like, I don't want to see that patient come up on my call screen because I don't know what else to do. Well, if you've exhausted everything you know to do, you've followed the pathway, you've done everything you can to create the flattest pouching surface, you've done the best match possible between the patient's abdominal surface and the pouching systems you have available, you've added adhesive, you've added mechanical support if that's an option for that patient. You've tweaked the system, but you still cannot come up with an effective pouch seal duration. And one thing you might have to do is modify what you consider acceptable, because in a difficult pouching situation, if you can consistently get 2 days wear time, that is a very acceptable outcome. That may be the best anyone could get. So make sure that your expectations aren't unrealistic. But I also wanted to mention surgical consult. There are times when patients benefit from surgical revision. Most of the time, the appropriateness of a surgical consult goes back to, what do you think is causing the problem? Why does this patient have such a difficult stoma? Let's say your patient has a very difficult stoma because they were an emergency admit for traumatic disruption of the bowel. And they brought the stoma out at a place that looked good when the patient was lying on the operating room table, but it turned out to be in a deep crease. And they thought that this was going to be a temporary stoma, but now, because of things that have happened post-op, they can't justify going back in for a major reanastomosis. So now the patient has a very difficult stoma, and they're going to have it for the foreseeable future. Well, then you would want to talk to the surgeon about possibly relocating the stoma. That's not nearly as extensive as doing a reanastomosis. They might be able to do this laparoscopically. There are many patients who have permanent stomas that were created under adverse conditions, and if that patient goes back to surgery, you can realistically expect much better outcomes, because when they go back, you can mark the stoma preoperatively, you expect normal healing, etc., etc. In contrast, if your patient has an unmanageable stoma because at the time of surgery she weighed 350 pounds and now she weighs 390, no, nothing's going to be better unless you can help her lose some weight. And so that would mandate a very just open discussion with the patient. I know you're so frustrated. I'm frustrated with you. I don't want you to have to live like this. The problem is, I really think that we need to have the stoma redone. But I can tell you nothing's going to be better unless we can get your weight down. Now, if we can get your weight down, then number one, your pouch might stay on better just at baseline. And number two, you would be a much more realistic surgical candidate. So yes, do think about surgical consult when you cannot come up with a manageable solution. Okay, so now we're just going to take selected patients. These patients you've seen before in our slide study, but we haven't done a comprehensive management plan. So we're going to go through each of these and think about, okay, how would we manage this patient? So this patient was my patient. You can see the axis where we wanted the stoma, and you can see where we got the stoma. And you can also see why, because this patient had significant abdominal obesity. Now, looking at the best pouch, you can immediately take flat rigid off the plate, off the table for consideration. That's not going to work. So we have to think, what's going to work better for this patient, an all-flexible pouch or a convex pouch? And when you look carefully at the contours and you factor in that his abdomen was relatively soft, you could try it both ways, and we did, but an oval convex system is what worked the best. And when you really look at his contours, you can see why that would be true. Do we need filler products? Yes, we've already talked about the fact that we need a little bit of paste to fill the minor defect on top, and we need a barrier ring rolled into a cigar shape to fill this. So paste, barrier ring, oval convex system. What about a belt or binder? Well, definitely he would benefit from mechanical retention, but he can't use a belt because it's way below the belt plane. And even a binder is going to tend to just hang off. What he really needs is a support undergarment, like biking shorts or some other kind of support undergarment. Most of the time patients can go online and find a support undergarment. You might also talk to your physical therapy department. A lot of times they're recommending lumbosacral supports for patients with major abdominal obesity, and they might be able to give you tips about what would be helpful for your patient. But definitely he needs support. And then if you can get a support undergarment, he would have two options. He could just keep his pouch tucked in under the support undergarment. The difficult thing is every time he needed to empty his pouch, he'd have to take the undergarment down and pull it back up. So it might be better to take the support undergarment, mark it, and send it to New Hope for modification, or you might have someone locally who could do the modification. And should we use additional adhesive? we elected to use everything at our disposal. So you could try it both ways, with and without. He actually benefited from the addition of adhesive. So to summarize, filler, oval convex, mechanical support, and the use of the adhesive spray. Here's a stoma in a wound. So we're going to use an alginate or a hydrofiber to fill in right around the stoma to absorb and keep the area moist. Then we're going to use a thin hydrocolloid or thin adhesive foam or tape strips just to create a pouching surface. When you look at the patient's abdominal contours, you see that they're irregular. You also still have a support product in place, and the abdominal wall was very firm. So firm abdomen, irregularities, I need a flexible system. So we use a flexible system because the stoma is essentially skin level, emptying at or below skin level. We would size the opening a little bit larger than the stoma. And we would make sure that we had very flat paste right around the stoma to create that ramp effect. What about a belt or a binder? Well, this is pretty close to the patient's belt plane, so we could consider a belt was the patient's ambulatory. And additional adhesive we did decide to use. That's because we almost always use that. So to summarize, we're going to manage the wound. We're going to create a pouching surface. In selecting the best pouch, we have to consider, are there decreases? No. Is the stoma retracted? Yes. Is the abdomen firm or soft? Firm. So that means I need low-level convexity with flexibility, okay? Or I need an all-flexible system. I can try both. I can try low-level convexity with flexibility, or I can try an all-flexible system. But I have to have that flexibility. And then we talked about filler products, adhesive, and belt. Here's our patient with a shallow crease. Very shallow, we can see the stoma, very soft abdomen. So if I have a stoma that's retracted but in a shallow crease with a soft abdomen, the stoma actually does protrude a little bit, then I would first try convexity. And because the abdomen is very soft, I would pick a convex system that provided support. The stoma itself was oval, so I would pick oval convexity to provide support in that area. Do I need filler products? No, because the oval convexity did a very nice job of filling the defect. But sometimes, if there was an additional defect, you might need to add a filler product. In this case, we did not. What about a belt or a binder? Well, this actually was very close to this patient's belt line, so we were able to add a belt, which added mechanical retention, which tremendously facilitated the pouching system. And this patient ended up not needing additional adhesive, just the right pouch and a belt. The patient had been wearing a flat, rigid, two-piece pouching system. Didn't work. But as soon as we switched the patient to oval convexity and a belt, problem solved. This patient had a urinary stoma. The major problems are retracted stoma and severe peristomal creasing, wrinkling. This was actually reversible because it was caused by pseudoverrucous lesions, so we put everything in place to deal with that, but temporarily we used paste just to give us a flatter pouching surface. Because the abdomen is firm, we wanted a more flexible system. The stoma itself is skin level, so we would like a little bit of convexity. Can you get that? Can you get low-level convexity with flexibility? Yes, you can. It's not going to be totally flexible, but it means that it's not going to fight with the abdomen. When we talk about some degree of flexibility, this patient had a firm abdomen, So we're going to fill the wrinkles. We're going to take a convex pouch, low-level convexity. We don't want extreme rigidity because it will fight with the abdomen. So we want a low-level convex system that has some degree of give to it, so it will contour to the patient's abdomen. What about a belt? That's very helpful if you're using a convex system, especially with a urinary stoma, because urine tends to undermine anything. Fortunately, it was close to the belt plane. We were able to use a belt. And additional adhesive would be optional. Here you have a totally different kind of problem. You have a stoma with a fistulous opening, and I'm hoping you can see this. I'm going to point out where the fistulous opening is. So you can see that you've got a lot of skin breakdown, and you have this fistulous opening here. So you've got stool draining from the stoma, stool draining from this fistulous opening. So we're obviously going to do basic crusting. We're going to protect the peristomal skin. And looking at pouch selection, the stoma itself protrudes, but that fistulous opening does not protrude. The rest of the surface is flat and soft. So you would go for convexity because you would be addressing that fistulous opening. So you would need support around the fistula. And obviously you have to adjust the sizing of the pouch to give clearance to the fistulous opening. If we cover up the fistulous opening, it's going to come off over and over and over again. So ideally, we would like a convex system sized to clear the fistula opening, and then we would protect the surrounding skin with a flat layer, very flat layer of paste, because we want a ramp effect, we don't want a retaining wall effect. Now, what about reusable pouching systems? You have some information about that in your module. We're not going to spend time on that today because reusable systems are very rarely used today. They are constructed typically out of metal and rubber. There are still a few patients who are using these products. If they are, ask them, tell me how you put this on. I'm familiar with reusable products, but I need to know exactly what procedure you use to apply this. Basically, the difference in a reusable system and a disposable system. A disposable system comes, the barrier is already in place, and the adhesive's in place. So you just peel off the backing, you may need to cut it out, and then you stick it on. With a reusable system, the pouch is designed to be washed and reworn, and the faceplate has no adhesive and no barrier. So you always have to wash out the pouch, add adhesive, and add a barrier if needed. So you just want to know from the patient, what's their procedure for cleansing the pouch? Which particular adhesive product are they applying to the back of the pouch? Do they use a barrier, and if so, which one? That's basically what you need to know. Now, there is one product on the market that I wanted to mention to you. It's a semi-reusable system, or short-term reusable. It is managed by New Hope, and it is secured with a silicone ring and a belt. It's the only system on the market that is non-adhesive. Now, obviously, since it's belt dependent, the stoma has to be in a belt plane. And the silicone ring that fits around the stoma basically is what locks it into place. There's a very unique feature of silicone. You'll get to see this when you're on site. And that is, if you put silicone against the skin and provide even slight tension against the silicone won't slide. The skin moves with the silicone. So it's like a non-adhesive adhesive. But you can see that the ring itself adds height. So this system is going to be most appropriate for patients who have a stoma in the belt plane. It's belt dependent. And the stoma ideally will protrude at least a little bit. Occasionally we've been able to get good results if the patient had a skin level stoma, because once you lock it down with the belt, it does push in around the stoma a little bit. So you do get a little bit of convexity. But the best outcomes are protruding stoma in a belt plane. And we think about this when we have patients who have a lot of allergies to skin adhesives, because this one does not rely on adhesives. You might think about it if you have a patient who has a lot of difficulties centering the pouch. And the reason I say that is because if I'm using an adhesive product and I don't get it centered correctly the first time, I've wasted that product. And so a patient could go through multiple pouches trying to get one in place. In contrast with this system, since it's just a silicone ring, if I don't get it quite right the first time, I clean my skin and reposition. So you might think about it for patients who have multiple adhesive allergies, patients who maybe have some coordination issues that is going to make it difficult for them to get the pouch in place the first time every time. Ideally, you think about this pre-op because you would deliberately site the stoma a little bit closer to the belt plane because it is going to be belt dependent. So I just want you to know about that. So in summary, you're going to have a lot of patients with difficult stomas, and there's not one single product that will work for every patient, and it's not one single pathway. Do this, do this, do this, do this. There is a pathway, but the pathway involves considerations. Think about this, try this, add this. So again, evaluate the patient sitting and lying, assess both stoma height, watch for the effects of peristalsis, and carefully evaluate peristomal contours. Pick a pouch that most closely matches the peristomal contours and is most appropriate for stomal height. Deep creases, all flexible. Shallow creases, you've got two approaches. Convexity, all flexible. In general, when your stoma is retracted to skin level, you would like to use low-level convexity, assuming no contraindications, like a crease. If your stoma is in a deep valley, in general, you want deep convexity, assuming no contraindications, deep crease. When you're selecting convexity, also think about how firm is the abdomen. A very firm abdomen, you usually want a convex system that has flexibility. In contrast, if the abdomen is very soft, you want a convex system that provides support. Use your filler products to create the flattest surface possible. Add adhesive if you think that just increasing the force of the adhesive bonding might make a difference, or when you're desperate, or we just did it routinely. We added adhesive because we found that it helped so many of our patients, and it was a very simple add-on. Add mechanical support if you think that would be helpful and if it's feasible. So if the stoma is close to a belt plane and your pouching system has belt tabs, add a belt. If the stoma is not close to a belt plane but you want mechanical support, think about a binder or a support undergarment. Tweak the system as needed, and don't forget the option for surgical revision if you think that would make the difference. Okay, that's it. Thanks a lot, and you will get to go over this when you're on site.